So I was actually in one of two ORs that finished on time. So I was looking at the clock as we were coming over, but I'm really pleased to join you today. Like we said, I'm Alika Lafontaine. I'm an anesthesiologist here in town. I'm a visitor to this territory. I'm a Red River Métis, originally born and raised in Regina, trained in Saskatoon, and then we made our way up here to Grand Prairie. Been here for about 13 years. I've had the wonderful opportunity to not only practice here, but also be a part of medical leadership, managing anesthesia for the regional hospital here and then also for the zone. And as I watched everything going on online and we're thinking through what I could say to help to summarize the insights that we've had today, my mind kept on coming back over and over again to a question that I think was on the periphery of some of the comments just recently, which is we know what to do, we know how to do it, but somehow we continue not to do it. And I'm going to just share just a really brief slide deck, just that I hope deepens the understanding of the insights that were shared today and provides a bit of a frame to understand this. So, our future health systems are really shaped by mental models. And they're really the mental models that we choose to believe and those that we choose to pass on. And so mental models are really beliefs that shape our behavior. All right. So when we believe something strongly, either because we grew up around it or it's a part of the language, culture, traditions, media, personal lived experiences that we've had, those really shape how we're taught to act. And in healthcare, there are sets of mental models that we all kind of pick up over time. And those mental models push us to treat patients a certain way. They treat us, they shape the way that we see ourselves and how we treat ourselves. One of the really strong mental models that I think has led to a lot of damage to our health system, especially in recent years, is this whole idea of self-sacrifice for the provider. The idea that if you're not sacrificing your relationships, your health, your time, if you're not skipping your kids' school musical or other things, then you're not really providing care the way that you should. And there's other mental models that relate to patients. The idea that patients should walk through door after door after door until they eventually find what they need, instead of just being told the first time, just go talk to this person, I know for sure that they can help you. Those are mental models that we kind of inherit and move on. Those ways that we're taught how to act, they really teach us what's socially acceptable. And so if you ever wonder why something that seems harmful in medicine continues to happen, I'd almost guarantee that if you dug into it, it's socially acceptable to act in that way, right? Why across Alberta's north for many years, we had purposeful absences of care, where communities would be told you get a doctor for a couple days a week or two per month, and that's kind of it. That was a socially acceptable kind of way that folks who managed those systems were taught how to act. And those really set expectations. Now, what's interesting about mental models is that they don't really have to be realistic, they don't have to be logical, and they don't actually have to work for your problem, right? Now, if you change mental models, you then change expectations and beliefs, and that's really how system change starts to occur. Now, I've had the opportunity to be a part of changing mental models for more than 20 years. Most recently, I was president of the Canadian Medical Association. It was a wild 3 years and a really amazing experience over the 12 months that I led our 94,000 plus physicians across the country. There were 6.6 billion mentions in social media, had more than 300 interviews by the end of the term. And over again, I had the opportunity to kind of lean in and help to change some of these expectations and mental models that we built our system around. During my year, we were able to have that historic investment in federal transfer payments, the $196 billion that was committed. There was a relook at whether or not licensure is something that we should reform across the country, which I think for the first time actually made its way into major news publications like the Globe and Mail. Really a refocus on primary health care. I think up until then we had really been focused on how do we secure kind of these ivory towers and large population centers run by specialists, and then historic advancement of Indigenous health reconciliation, including apology to Indigenous peoples that I was able to be a part of. So in order to understand mental models, we really have to understand the stories of the systems that we work in. And so I'm going to try and tell you the story of Canada's healthcare system in less than 10 minutes. So Society, if you think of it as like a place where things grow and thrive, tends to really have two main elements. The first is that there has to be a good economy. So there has to be a way for us to exchange value and for us to produce value. And along with that, you end up having social fabric. So if you have good economics and you have reasons why people kind of stick together and work together, you end up having fertile soil where things can grow. And there are various health and social systems that spring out of strong societies that have really good economies and that have strong social fabrics. So things like health, education, social supports, housing, et cetera. Now, economics and social fabrics, they kind of wax and wane over time. You know, you have economic crashes that happen from time to time where people struggle through that. You have times where the social fabric frays for a variety of different reasons, whether that's war or global events like famine or other types of issues or things like pandemics that really fray whether or not people decide to continue to work together. And when you end up having the soil that everything grows in kind of wane, you end up having declining systems. And we've really seen this over the last few years as we've gone through, I think, 3 different economic crashes over the last 10, 15 years. And we've had, a once-in-a-generation pandemic. I expect we're probably going to see another pandemic sometime soon. But as a result, our systems have really wilted. And at times, it kind of feels like these systems are on fire. Now, if you look back at the history of the healthcare system, and to all the historians and deep policy people, I do understand I'm oversimplifying this, but for the sake of story, I'm going to simplify it. But prior to 1947, healthcare was really a mix of churches, charities, and private entities across the country. There wasn't really a lot of programs that were provided by the public service, and there wasn't really infrastructure in place for what we see as healthcare as it is today. Now, from the 1950s to 1982, Canada kind of moved into adopting public healthcare, and the thing that triggered that, I feel, based on most of the reading that I've gone to and folks that I've talked to across the country, is that it really was an economic imperative for Saskatchewan. The place where I grew up was going through really hard economic times. Folks who were mainly in the agricultural business, which was the main tax base for the province at the time, they were getting sick. They were going into private healthcare services. Once they couldn't pay, they were turfed over to either the charitable or nonprofit part of the healthcare system. And because care was not provided in the most supported type of way, people got sick and they just didn't get back to work. And so Saskatchewan really had a choice where they either continued to let people go through the system where they paid until they couldn't, and then they moved to other places where they received substandard care, or could invest in a public health care system and maybe get themselves out of this downward spiral that they were caught in. And this was first adopted in Saskatchewan, but quickly spread across the country as government started to see, hey, this is actually a really good idea. If we provide healthcare services to folks, we can get them treated, and then we can push them back out, and they can be productive members of society that contribute to economies and social fabric and all these things that make up, a strong soil for these systems to grow in. Now, over time, more and more the public service ended up being focused on, and there was this real expansion that happened. In Saskatchewan in particular, this expansion really took the shape of, duplication of services. So you had maybe, a small clinic or hospital that did basic health care, so they decided to expand into another community. The way they do it is they build the same sort of building, they'd have the same sort of people, the same sort of team structure, and so you'd maybe have like one physician and a couple nurses and, a mixture of different administration, and that would kind of spread across the whole province. Now, from the 1980s to 2010, that expansion hit a wall. Part of it was that they didn't have enough money to run all of these different access points. Part of it was that they ran out of people. Part of it was that equipment is really expensive, and you just can't continue to buy things over and over again to distribute without having some sort of plan. You just can't put the same thing everywhere. And so from the 1980s to 2010, there was a real focus on how do you improve systems, and this is where regionalization happened. Now, in the 90s in Saskatoon, where I trained, folks moved from being able to receive any type of care at every hospital in town to suddenly there being a trauma center in town. Suddenly, if you had psychiatric care, it was on the floor of one of the hospitals instead of all of the hospitals. delivering babies and receiving obstetrical care was focused on one center. And so that regionalization really pushed forward through the 90s in particular into the early 2000s. Now, from 2010 to 2020, we really started to see the impacts of economic and social decline. And there really was this era where austerity and political polarization really began to build. And I think for folks who graduated in practice since, the late 2010s or early 2010s, late 2000s, they haven't had a period of time where government has really talked about reinvestment. It was constant talk about how do we cut services, how do we make sure you get more value for dollar. There was a lot of code words that were introduced. I think stewardship at the beginning was a really great term, but I think what it came down to in practice was it was a bit of a way for people to argue that, well, you can't stewardship funds, so we're just going to take them away and we're not going to provide them back. And so this era of austerity really continued on and was magnified into 2020. Now, right now to 2020 to today, we really have worsening access. Lots of people are questioning, should we still have a public healthcare system? We've never had more support for private healthcare, which is a very abstract concept that I don't think the majority of people actually know what that means. But, it sounds good. It sounds better than, the public system that we have right now. So, exploring all these different things is something that more and more of our patients and providers are exploring, and communities are kind of asking questions about. And then there's also things like misinformation. I think service arbitrage, which is the idea that you have resources and those are being arbitraged into other systems. For example, virtual care is affecting community-based care, kind of brick and mortar in-person care in some parts of the country. When we all know virtual care can only go so far in providing care, eventually you have to transition to folks who are there in person. People are really negotiating and kind of arbitraging value. We've never had higher expectations for what the healthcare service can deliver and never lower morale about actually providing it. And so I'm going to suggest that based on that story, there's really three core issues that we've looked at over and over again as the healthcare system's kind of gone through its cycles since the 1950s. The first was a question about access. If someone doesn't have access, how do you solve that? The second is that how do you manage complexity? So if you have new technologies, new services, if you question safety, question quality improvement, if you have issues like not understanding rural care, for example, how do you address that complexity? And finally is how do you get the most out of what you spend, which is efficiency. Now, over time, we've had these really established mental models that have grown over the past few decades, where if you have the problem of access, the solution has always been new access. So sometimes that's meant building new buildings. Sometimes that's meant having new people trained. As we've moved into recent years, that's shifted into how can you get different people who are trained differently to do the same thing. And this is where you get into conversations about scope of practice and other things. We moved from buildings that are stationary and equipment that's stationary to now having mobile units, mobile healthcare centers, mobile MRIs, et cetera. When you look at complexity, the solution has always been new specialization. So we don't understand this problem, and so we're going to create new training, new certification, et cetera, et cetera. And then with inefficiency, how can we create new ways of measurement so we can understand kind of how we should change what we do and how can we introduce new technology? Now, our old problems no longer are our current problems. So when you look at access and building new access over time, you actually run into this problem of fragmentation. I asked the question across the country in the year that I was CMA president, how many of you know who to call for this specific problem? Who has a map of where all providers are in real time? And it's quite striking when you compare it to the way that you would do inventory in any other area, where it's very unclear what people need or where that need can be met. It's kind of like walking into a superstore and then walking out and telling people you weren't able to get groceries. But when they asked you, well, where did you go? You'd say, well, I don't really know. What were you looking for? I don't really know. And was there stuff on the shelf or not? Well, I don't really know. So we're not really tracking things, and we tend to collapse together a lot of things that aren't actually similar. So family physicians, for example, we know that a family doc's not just a family doc. Family physicians can do anything from full scope, longitudinal relational practice to having a bit of a more focused practice, either because of need or interest. Certain people don't provide certain services or can't provide certain services, but it's the same for nurses. Nurses across the hospital, especially during the pandemic, we'd be looking for folks who had specific skill sets in order to deal with problems. And they'd be pulling public health nurses, and the public health nurses would be saying, I don't have that expertise. I can help in other areas, but they'd be told, well, you're a nurse, and so you can go ahead and do this, right? One of the things that I'm confronted with that I think is unique to rural practice is, as an anesthesiologist, I'm kind of treated as not a generalist, right? When a child comes in and they're less than a year old and they have a problem, if it's life-threatening, I'm expected just to provide care. Now, that is not something you'd ever do in the city, right? I would never treat folks who were less than 2 years old if I worked at any of the major hospitals in Edmonton. Now, can I provide emergency services? I probably can, because there's no one else, but is that the best way to go about doing it? It probably is not. When we look at complexity and new specialization, I think we've really moved into this over-specialized era of medicine, where every time that we look for solutions, we're constantly looking to see how we can train people longer and with new certifications. I sat on the Royal College of Physicians and Surgeons of Canada Council, and this was really drilled home to me when someone presented the idea for a new specialty in general surgery, which was being a generalist, which is very ironic because they're trained to be general surgeons. So, the idea that you've over-specialized your training to the point that people can't do the bread and butter things that they're expected to do, things like taking out a gallbladder, lumps and bumps, et cetera, and that they can't use those basic foundational learnings to kind of extend it into more challenging situations. I think you can really see that we've really narrowed our view and gotten a little too over-specialized in how we impact things. Now, inefficiency with new metrics and technology. Over time, if you keep the same sort of metrics or you include the wrong people in designing those metrics, you get manipulation of metrics. I see this commonly in surgical environments where folks, if they know that if they have a longer wait list, they can get more access to healthcare services, they get that wait list as long as possible. Now, that's a terrible experience for patients because they're waiting longer than they should. It's not a great idea for healthcare utilization because one person can only do too much, but they're incentivized to manipulate the metrics in that way because they want as many surgical days as possible. You also end up getting uneven adoption, and this was a really surreal thing for me to experience when we moved over to Connect Care here in Alberta. As I'm on my phone, texting a friend with a secure, well-encrypted direct messaging system, as I'm listening to the fax machine going on behind me. And you see across different locations, especially across here in the north, that there's a lot of places that don't have the same sort of technology or the same level of technology, and as a result, we just pile up newer ways to solve old problems, but we're not all adopting the same sort of way in any sort of consistent approach. So when you have old solutions addressing new problems, your maladaptive solutions actually make today's problems worse. And I would actually argue that in this area, particularly around access, I think it's really clear here, just bringing in more and more people to do the same thing when we haven't actually defined what that thing is, and we're not really sure if they could do the same thing properly, we're just creating problems for ourselves. And this is not an argument that people can't do similar tasks. One of the most compelling things about the way that they do long-term care in places like Norway, which we often refer to, is that people meet in a meeting in the morning, and they task shift and they task share. They just go around in a circle and say, who has time to do this? Who can do this safely? And do you need help doing this? Or can you go off and do it yourself? But we don't have those conversations. We have different groups arguing that they should have similar scopes of practice, and then we all kind of live in our own little silos. In the hospital, if you get an evaluation out of the hospital that's not acceptable to a consultant in the hospital, you end up getting the same blood work, imaging, et cetera, all again. Which just ends up being, at the end of the day, a waste of resources and a waste of both the patient and provider's time. Now, mental models can be abstract or concrete, and I think this is one important thing to think about as you kind of take the things that you've heard today and you shape them into what you think are mental models. When you have a very abstract type of mental model, the issue is really undefined. But what's great about those is that you can project yourself into that problem. When we say things like rural, what does rural really mean, right? Rural here in Grand Prairie, where we have a Costco, is very different than rural in Beaver Lodge, which is near a Costco, but not does not have a Costco. And both of us are different than Fort Vermilion, which is, you know, a different type of rural, or Alert Bay in the far north, which is, once again, a different type of rural. And so sometimes we give it different labels, like things like remote, but what makes rural and remote different from each other, and how does that relate to what we're actually trying to solve? Now, when the issue is undefined, it's pretty easy for systems to quickly say that this is not our problem. When the issue gets a little bit more concrete, often systems tell us that it's your problem. You know, when we were talking about burnout in the very early days of having that be a popularized kind of thing for people to talk about, health systems would commonly say, well, we appreciate that you're going through something, but that's not a problem here. You're going to have to solve that yourself. As you get more concrete, people start to see that the issue actually happens in the system that they work in. And so they start to look at ways that they can help, but they can't actually solve. I think for a lot of Indigenous health issues, this is where the mental models kind of live, where it's just a little bit concrete, but not concrete enough. Everyone's happy to help with Indigenous health issues, I think, nowadays, but very few people believe that they can actually be solved, right? And then if you get ultimately concrete, then the issue is fully defined, and people believe that they can solve it, and you can actually have concrete impact. Now, if you're moving from abstract to concrete mental models, there's kind of three different phases that I really encourage you to kind of go through. The first is, if you're trying to explain something like rural, you have to be able to explain it to someone who doesn't have any of that lived context. So if you have someone who doesn't understand anything about what it's like to live rural, work in the health system in kind of a rural location, your explanation needs to be detailed enough to actually communicate and transfer that knowledge. As you start to transfer that knowledge, you also start to realize that there's places where these problems are problems and places where they're not. I've taught about anti-racism for the last 20 years. One of the things that I talk about lots in sessions where I'm training folks is, although racism is a problem everywhere, it's not necessarily the problem here today, you know? And so if you can't use that way of explaining to predict where a problem is going to be and where it's not going to be, that explanation is not actually that helpful. And finally, you have to be able to look at variables that you can change to make the problem worse or better, right? And so if you're looking at access to rural care within a community of 70,000, there's probably specific concrete ways that you describe variables that are a lot different than Fort Vermilion, which is a community of a few thousand. And those may include things like access with roads, you know, weather conditions, you know, et cetera, et cetera. So going back to our abstract versus concrete mental models and just kind of showing how this links to each one, I'm going to suggest that throughout the day we've had a lot of insight. I've heard a lot of the presenters present before, so I kind of picked some of the ideas from your previous presentations as I kind of share this, so hopefully that resonates with viewers. But, you know, if you look at the mental model that we've been using up until now, more workers mean more access. You know, when today, if we're looking at a concrete mental model, aligned health human resources means more predictability. So it's less about whether or not we can simply have like increased capacity, whatever that means, to how can we make sure that we have a predictable type of capacity that covers the areas that we have. We've often been told that we need to deploy to rural, so we train people in certain places and then we kind of ship them off to rural locations. Sometimes you get lucky, and a person like myself who grew up in, you know, Saskatoon and Regina ends up coming to Grand Prairie and staying here for 13 years. But what probably works better is to actually embed people in rural locations, to actually have them train and live and other things. One of the things that I've always heard joked around, no matter the rural community that I've been at, is the best way to keep the doctor in town is making sure they marry somebody from in town, right? Instead of looking at parallel services, looking at interlinked services that kind of share information and knowledge. And then finally, a shift from a service delivery paradigm to a service navigation paradigm. If you're looking at things like complexity, you know, we've approached complexity in health systems by escalating to experts. You know, I've reached the edge of my knowledge, and so how am I going to transfer this to somebody who knows more about what they're doing or has more experience? To this new model where people are really talking about empowering generalists with tools. You know, how do we make sure that people feel supported in teams? We did this across, you know, the zone when it came to intubations that were difficult. You know, we'd actually have somebody on video, and as they went through it, we'd give advice as we were watching them on video and support them as they were trying to do their procedure. Kind of moving from role-based care to capacity-based care. You know, there's these different things that people have to do, but who's actually there to provide the care? And how can we frame things around that? This idea of distributing specialists to supporting whole scope specialists. So how do you support people who actually provide the full scope of care? this credentialed hierarchy to interchangeable capability within shared safety frameworks. I think there's a lot of things that we have to think through as we're expanding scope of practice. And these include things that we normally wouldn't have crossed our minds, things like liability and litigation. What's the reason why folks who can do the same thing don't share call? Part of that is risk liability and full scope of practice when you're working after hours. I'm always struck that that family physicians can't own pharmacies, but a pharmacist can both diagnose and dispense medication. These are not to say that there's anything nefarious going on, but these are things that we actually have to think through as we change our systems into what they're going to be. And then finally, with efficiency, compliance to indicators to alignment with intent. Are your measurements actually leading to what you're trying to produce out of your system? Incentivizing use either through, rewards or punishment to an overall return on impact. What we're really doing in health systems is I think we're buying health, and the only way to save money in healthcare when you look at it from a 30,000-foot view is to not have people utilize healthcare, right? And so how can you have people turn to community and turn to other places where they can maybe get the same sort of services, but they're not within kind of this healthcare paradigm that we have. And then finally, admin-defined efficiency versus citizen-validated value, which I think is something that we just heard from the last panel. So just before closing up, I'll just note one more thing just about abstract versus concrete models. Abstract models are really great to scale adoption. So if you talk about rural healthcare, you'll get a bunch of people kind of projecting themselves into that paradigm and saying, oh, this is great, rural healthcare, I can really support this. The problem is that abstract mental models don't actually solve problems. They just get people bought into feeling like they're a part of a movement. In order to solve problems the best way, you have to have some level of concreteness, and at some point, the solutions don't actually match the problems of everybody who's kind of part of that big group that's kind of adopted that abstract mental model. And so I think in healthcare, because we constantly want templates and other things, it's tough because we have to recognize that we're not templatable in a lot of these different situations. We have to get concrete to the point that some of the solutions actually don't apply to other places, in the same way that Grand Prairie is a rural location, our solutions won't necessarily be the solutions that will work in a place like Fort Vermilion. Just some final thoughts. Mental models drive healthcare behavior. We're stuck in old ways of dealing with new problems, and as a result, our problem solution fits actually get a lot worse, and I think we're actually making the system worse as a result of continuing on with the ways that we've always done things. I think our solutions are known. You've heard a lot of them here today. But I think before jumping into the solutions, I'd really encourage folks to really unpack the mental models that underlie those solutions. That way we don't just go back to our old behavior after we try and implement them. So thank you very much, and congratulations for a wonderful day.
Thank you, and deep and sincere thanks, Alika, for taking time out to join us, and and we are so pleased that you were on the right OR today to be able to kind of join us today. And thanks to everybody online. It was a remarkable summing up and some common themes, and we'll be sharing the results of this event online, and also a future ongoing rural health policy webinar series, because we want this to grow.